We are from the Medical Intermediate Cardiac Care Unit. We were trying to decide what to pick for our topic for this project, and we all talked about how we've only been in maybe 2 to 3 code blue situations within our time as new grad nurses this past year. We all were talking about how we'd like to sharpen our skills and become more confident during code blue situations. So we decided to do our presentation on MICC codes. This presentation was done by Haley Ames, Jessica West, Rachel Spinner, Alex Wheeler, and Haley Woods.
Here's some background information on the importance of MICC codes. According to the American Heart Association, the highest survival rates from a witnessed sudden cardiac arrest are in people who had chest compressions and defibrillation delivered quickly. Survival rates decrease 7 to 10% for every 1 minute of delay in CPR. Annual BLS/ACLS training may not be enough. According to Curran, skills gained from this training can deteriorate in as little as 2 weeks. According to Prince 2014, the unexpected benefit from MICC codes not only improved better patient outcomes, but also higher team satisfaction, morale, and camaraderie reflected in the post-follow-up surveys.
So the PICO question we chose on a medical intermediate care unit while implementing MICC code simulations improve nursing performance and confidence, thereby improving patient outcomes during medical emergencies.
This article focuses on 2 areas for improvement during emergency situations. The first being the confidence level of medical professionals. The second being retention of knowledge and skills gained from BLS and ACLS courses. There can be long periods of time between training courses, and with a potentially low volume of medical emergencies, depending on the type of unit you work, the acquired skills from the BLS and ACLS courses can quickly deteriorate and translate to low confidence and ability to perform among nurses and CNAs. To improve performance and confidence, a MICC code program was implemented on 2 progressive care units. Over a 2-year period, each unit conducted quarterly MICC codes at various times, as well as various shifts, to provide more staff member opportunities. It was beneficial for the simulations to be conducted at random and on a home unit as opposed to scheduled training sessions outside of the unit, because it was more realistic than a scheduled training session. It became important because it allowed staff to identify and locate emergency equipment, resources on the unit, who to call and where to call them, ultimately making them more confident with their surroundings and abilities during emergency situations. The outcomes of this program were assessed with debriefing sessions they would have immediately after MICC codes. They could identify areas not only focusing on staff improvement, but also existing code processes, including a location of equipment, maybe it was too far away, needed to be somewhere closer. And they also use an observational tool. They use the observational tool based on American Heart Association guidelines. So according to AHA guidelines, assessing and calling for help, the goal is within 20 seconds. So during this program, over a 2-year period, the response times on these units went from greater than 20 seconds to 15 seconds on average. The second observational tool they used was measuring initiation of chest compressions. So according to the American Heart Association guidelines, the goal is within 60 seconds. And on these units, during this program over 2 years, their response time went from greater than 70 seconds to less than 40 seconds. The third one is the delivery of the first shock. So initial defibrillation, the goal of that is to be within 180 seconds. And on these units, the response times went from greater than 180 seconds to 120 seconds on average. The other thing that the facilitators addressed were potential cons to this program. So there may be some negative response to the timing of the simulations and the being at random during a normal shift. That can be very stressful. So facilitators assisted on the floor with patient care. They did what they could to help out the nurses during these mock codes to help reduce some of that stress on them. Many staff members also reported that they appreciated that they didn't have to prepare ahead of time, they didn't have to come in on their day off, and they didn't have to wait in line. So ultimately, there was a positive response among the staff members to this program.
So this is Article 2, mock code, code blue scenario requested by and developed for registered nurses. So essentially what this article was talking about was a group of nurses requested this on various surgical units. They got together with the Quality, Patient Safety, and Risk Management Department, and they teamed up with the Clinical Learning and Simulation Center. So essentially what they did was just kind of worked on the recognition and deterioration of a patient, first signs of someone going south, I guess, and using a team approach to provide timely care and communication and appropriate code blue response initiation process. So the goal essentially in all of that was a practice code in a safe, simulated environment to improve provider confidence and ultimately improve patient safety. So when they were going through the motions of this, the targeted learning objectives were developed along with a programmed mannequin to determine the effectiveness of the compressions and airway management. So this mannequin was able to determine like the actions and inactions of the nurses, particular drugs that weren't administered at a certain time, compressions not deep enough, too shallow, too fast, too slow. And the outcome of all of this, staff members said they felt more confident, calm, and prepared for a code emergency. Like I said earlier, graduate and novice nurses participated in this code, and they were videotaped during this. And so they were able to afterwards sit one-to-one with someone and kind of go through the process. Like, you could have done this here, or, good job on this. We'll work on this. And also, actually, I should backtrack a little bit. And before this, they were actually shown videos on how to administer medications, how to draw them up, where the backboard was, how to put together the ambu bag, things, just little things like that could really kind of make a code not go as well as you'd hope. But yeah, like I said, they were debriefed with an observer to discuss the actions or inactions of the RN and kind of work on that confidence level.
Article 3, longitudinal exploration of in situ mock code events and the performance of cardiac arrest skills. The objective of this study was to determine whether a program of mock codes improves group-level performance of in-hospital cardiac arrest skills. In-hospital cardiac arrest affects 200,000 adults in the United States each year, and resuscitative efforts are often suboptimal. Our primary outcome of interest was a change in CPR fraction, which was calculated by dividing the cumulative time that the mannequin received chest compressions by the total pulseless time. The secondary outcomes of interest were to time the first dose of epinephrine and to time first defibrillation. They conducted the mock codes in an urban teaching hospital. Mock codes occurred on telemetry and medical surgical units on day and night shifts. The codes were managed by unit staff and members of the hospital's Code Blue team, and data was recorded by trained observers. Data was summarized using descriptive statistics, and repeated measures outcomes were calculated using mixed effects model. 57 mock codes were included in the analysis. The outcome showed improved rates with the initiation of compressions. However, there was no significant changes with the administration of epinephrine or defibrillation. Lastly, the article mentioned that the traditional training interval of 2 years for ACLS and BLS courses is inadequate for the needs of hospital staff who may encounter cardiac arrest on an infrequent basis.
Another way we can improve our practice using mock code simulation is by using 5 Alive. There's several hospitals that actually use this program. 5 Alive is a mock code simulator that helps improve the CPR and time to defibrillation along with the nursing self-confidence. They use it on tele floors and med surgical floors, and they actually do really cool stuff. So they do this on a random units every month in the hospitals that use this program, and they actually record the mock code, and then after that they sit down and debrief and watch the recording and see what they could have done better and how they could have done better. They also take a quiz beforehand and say how confident they are in codes and then how confident they are after the mock code. And initially, when they first started this program, they started seeing that people were actually scoring worse, saying that they were less confident after the mock code. And then after multiple mock codes, they saw some improvement in nurse satisfaction and confidence, and also in the time to CPR and the time to defibrillation. So each time that they've done the mock codes, they have shaved off more time and gotten to do CPR and defibrillation faster. This is another reason why using a mock code simulation in any of our units, I think, would improve all of it for everyone, especially in a nurse residency setting or in a setting where we don't really get a lot of codes, such as the unit that we're on, the MICC.
Optimizing patient resuscitation outcomes with simulation. The environment that this was performed in was the Texas Health Harris Methodist Fort Worth Hospital, a 710-bed tertiary care facility in an urban setting. What was being measured was the effect of delineated responder roles, training of subject matters experts known as Code Blue champions, and training through simulations have on communication and time to first defibrillate while awaiting the official code team. What resources were used to being evaluated? Over the course of 8 months, intensive training was given to self-selected Blue Code champions. A number trained was not given, who were then given the responsibility of training their respective teams using simulations in a realistic patient situations. After each simulation, observers managed a debriefing to cover the things that went well and what needed to be improved. The outcome was that no information was gathered on numbers prior to training. However, post-training figures, when compared to national figures, 214 patients experienced cardiopulmonary arrest. Of these patients, 74% immediately survived with the return of spontaneous circulation, compared with the National Registry threshold survival rate of 44%. Of all patients who arrested, 33% survived to hospital discharge, compared with the national benchmark survival rate of 17%.
Here are some recommendations and next steps that St. Luke's can take in regards to mock codes. We know mock codes are the best places to make mistakes, so we recommend coordinating mock codes quarterly throughout the hospital, whether planned or unplanned, so RNs can practice and remain confident in their skill set. Studies show that when RNs are confident in their skills, whether it be communication or performing CPR, the outcomes of the patients exponentially increase for the better. We also thought it would be beneficial to offer a Code Blue class for new graduate RNs while they're still in orientation, so they can become acquainted with the code cart and the dynamics of a code here at St. Luke's before taking care of patients on their own.